All right, so I'm Dr. Dupre. I'm a rheumatologist, and a rheumatologist is somebody many people like to call a joint doctor, but I'm going to get a little bit more into what that is in a little while. I'm also the Chief Medical Information Officer for the physician group, and I'm also an Associate Clinical Professor at LSU, which means I teach residents as well. So I do a few things, but more importantly, I am local. I grew up in Houma. I went to college at Nichols. Then I went to LSU Medical School, and then did my residency here in internal medicine at Earl K. Long Hospital, and I've been here ever since. You know, for 7 years I've lived here now. I love the community, and so I wanted to give a good overview of arthritis and let people know this is very common in so many people that we're going to go over a few different things. We're going to go over 3 different types, and I'm going to point out what's most common and what do men have to worry about, and you know, what more affects women in some cases too. So first of all, I'm actually going to talk about what we try and figure out in the office is what type of arthritis is this. We've got 2 main types that we're trying to figure out when we're sitting down with someone and talking with them when they come to us with complaints of joint pain. First, we're trying to figure out first, is it arthritis? Is it in the joint? Or is it tendonitis? Is it outside the joint? Mostly today I'm going to talk about actual arthritis. When we get down and it's actually arthritis, we try and figure out first, is it inflammatory or is it non-inflammatory? And what do I mean by that? Non-inflammatory means wear and tear. The joints are wearing out and they hurt and ache. Inflammatory means your body's immune system is attacking the joint and causing swelling and pain and inflammation. And so we have several different types of arthritis underneath each of these categories. Wear and tear, the most common is osteoarthritis, and that's what most people come to see us for. But there are all kinds of other disorders that are also degenerative and wear and tear, which include some rare things like diffuse idiopathic skeletal hyperostosis. I put that on there because I just like to say that. It's very rare. And then there's degenerative joint disease or disc disease, where the discs in the spine actually wear out and lose their elasticity and can cause arthritis as well. Now, under inflammatory forms of arthritis, we actually have rheumatoid arthritis, which is one thing we see very commonly as rheumatologists. And then we have gout, which is actually many primary care doctors end up seeing more than we do because people can treat gout pretty easily, and we'll talk about that as well as we go. So overview, today what I'm going to try and talk about most is osteoarthritis, rheumatoid arthritis, and gout. But first I'm going to give a little bit of an overview of what's common between many of these. So when we say arthritis, what we typically mean is inflammation in the joint. The itis means inflammation. Arthralgia means joint pain. And so we've got several things we're trying to figure out. And if you see arthralgia or myalgia, it's just doctor speak for joint pain, muscle pain. Really, medicine is about learning a different language so we can confuse all of our patients, right? So, because it could be easily said, it's just joint pain, it's muscle pain. But we have to use all these weird terms to convince the insurance company we're doing something, right? With arthritis, you can get joint pain or muscle pain, and it has to do with the way the nerves work. You may not have the joint pain, but you may feel pain in the thigh, yet it's the joint that's the problem. Or you may feel pain in the joint, yet it's the muscle that's the problem. That has to do with the way the nerves come back up into the pelvis or around, and they can actually get confused signals. And so sometimes it's very hard to determine what's in the joint and what's outside the joint. Is it the tendon? Is it the muscle? Is it the joint? We try to do that as much as we can by talking to you, finding out what bothers you, when it bothers you, how it bothers you, what are you doing when it bothers you, and what are you doing when it doesn't bother you. And sometimes that helps us decide. Now, I was actually talking with someone else about this a minute ago. Joint stiffness is a common theme in arthritis, all of these forms of arthritis. Now, the actual joint stiffness can help me decide, is it wear and tear or is it inflammation based off how long you experience it. But there are a couple of caveats to it. There's one form of joint stiffness when you sit down, and then when you try and get back up again, that joint just doesn't feel like it wants to keep moving. We call that gelling phenomenon, where you've sat down and the joint kind of feels like it's congealed, and then you get up and move and it starts to get a little better. We also have morning stiffness, which is very similar. You wake up in the morning and the joints don't want to move, but it usually lasts longer than when you've sat down for a while. And how long that morning stiffness lasts can tell me a lot about your arthritis. And so I'm usually asking those questions when people come to see me in the office. What other things do we see with arthritis? Well, joint popping, clicking, joint laxity. A lot of times the popping and clicking is because our bones grow a little larger and we get these abnormal projections on the bone, and a tendon snaps over it when we move. Or with the cartilage actually can get eroded, and the damage can actually, the cartilage can actually slip on itself and cause a popping. Within the joints themselves and the knuckles, I know a lot of people wonder, you see me, I'm doing this, cracking the knuckles. Well, is that going to give me arthritis? No, it doesn't actually give you arthritis. Joint cracking in the knuckles is really just you pulling some of the nitrogen inside the joint fluid out of fluid, and they pop into a bubble. It takes another 20 minutes. Notice I can't do it again. For those nitrogen bubbles to dissolve. It really doesn't cause any arthritis. So, first question most people ask is that going to give me arthritis? No, it's just something you can do. Joint laxity can occur in osteoarthritis, and bony enlargement and joint swelling can occur in all of these forms of arthritis, but to varying degrees and varying levels. There are over 100 types of arthritis. And that's why we have doctors who specialize in different types of arthritis. One quick thing, and then we're going to hold other questions until we break and then the end. So if you, go ahead, real quick. That question is, it depends. Because the arthritis can cause carpal tunnel, or carpal tunnel can occur without arthritis. It can be either one. Okay. So over 100 types of arthritis, including osteoarthritis, then DISH, which was my favorite just because I like to say it, remember. Rheumatoid arthritis, gout, pseudo-gout, which means it looks like gout but isn't gout, and there are different types of that. Osteonecrosis, which is erosion and damage of the bone in the joint, which can cause pain in the joint and cause arthritis. Metabolic forms of arthritis, where our own body's processes actually are causing that arthritis. And then there are other immune types of arthritis, like lupus, that can cause an arthritis. It's very different than rheumatoid arthritis. And so there's all kinds of different arthritides out there. So what in the world is a rheumatologist? A who? A rheumatologist. We're actually a subspecialty within internal medicine. And internal medicine usually means we treat adult people for all kinds of different diseases. Rheumatologists focus on autoimmune diseases. And these are diseases that the body's own immune system begins to attack the body itself. So things like rheumatoid arthritis, lupus, scleroderma, ankylosing spondylitis, all these weird diseases out there where the body's immune system starts to attack itself. All of these immune conditions usually involve some form of arthritis, and so we have to become experts at arthritis by proxy. So we see and we have to delineate what is wear and tear, what's inflammation, what's autoimmune, and we have to know how to treat them all medically. Notice I said medically. Rheumatologists don't do surgery. What we do is we treat everybody with medical management and other lifestyle changes up until the point you need surgery if you end up needing it. And then we actually tell you if you want surgery, we send you to an orthopedist. So remember, we don't do surgery. We do medical management of arthritis all the way up until that point of surgery. So first thing I'm going to talk about is the most common form of arthritis out there, and that's osteoarthritis. So what's osteoarthritis? Osteoarthritis is actually one of those wear and tear arthritides. There are some components of it that are heritable. What most commonly happens is that the cartilage within the joint, the lining of that joint itself, breaks down over time and it causes a mild local irritation. That local irritation causes inflammation and some mild swelling, and that swelling and inflammation can cause pain. As the cartilage breaks down, the joint becomes loose. And that looseness the body can detect, and it begins to grow the bone around that joint larger to try and prevent it from becoming too loose. And we get bony enlargement. And so that's what osteoarthritis is. And many people notice it in their first thumb joint, some of them in the knees and the shoulders, in different areas. This leads to pain, stiffness, swelling, all of those symptoms I was talking about earlier, limitation in the ability of the joint to go through a full range of motion, and deformity of the joint itself. Excuse me. Can affect almost any joint. There are some that it really doesn't, and so if we see that arthritis in a particular joint, that may lead me down a different path, but it can affect most of them. The most common are the knees, the hips, the small joints of the fingers, the base of the thumb, the lower back, the neck, and the acromioclavicular joint. That joint is actually the joint on top of your shoulder. The true shoulder joint itself is very rarely affected by osteoarthritis. It's usually the joint on top of the shoulder that ends up irritating the tendons right underneath it that causes most shoulder pain. So that's a whole nother talk in itself, actually. But the acromioclavicular joint is one that's commonly affected as well. About 21 million people in the United States have osteoarthritis, and we like to say about over age 65, there's probably 70% of people we could find osteoarthritis on x-ray, but not everybody's knocking on my door. Why is that? Well, not everybody has inflammation. Not everybody feels the pain. Some people have osteoarthritis and wear and tear but don't feel it. They have the bony enlargement, they have x-ray changes, but they don't feel it. And so they don't end up at a rheumatologist or an internist, which is actually okay because we actually don't have medicines that stop the disease in its tracks. Most of our therapies are to try and improve your mobility, decrease the risk of progression, and to reduce the pain and swelling that you have and the stiffness. So really, what does happen in osteoarthritis? Well, the first thing that typically happens is that the cartilage itself becomes less pliable, less elastic. It can't stretch as well. It doesn't compress as well. It doesn't retain its shape after compression. And this happens in most of us because the cartilage itself, we actually inherit an inability to repair it. Most of the tissues in our body, including bones and cartilage, constantly undergo breakdown and repair, breakdown and repair, breakdown and repair. And this is a constant process. These are living tissues. They're not static tissues. They are alive. And there are some people who start to do that repair. Instead of repairing properly, we repair it with something that's a little more stiff than normal cartilage that we had when we were younger. And over time, as that keeps going, the cartilage actually breaks down easier and gets damaged more easily. And then underneath the cartilage, the bone gets irritated, and the bone starts to grow thicker. And then underneath that and on the sides, spurs start to develop, and that actually irritates the tendons. As the cartilage gets damaged, your body wants to repair it, and so it causes inflammation, it causes swelling, and tries to repair it, but the process is continuous, and so it can't repair it, and so it just continues this progression of worsening. The synovium itself, the lining of the joint, can become inflamed either because of this process or because little pieces of cartilage get stuck in the corners and irritate the synovium itself, the lining of the joint. And so there's a lot of reasons for the inflammation and the swelling and the pain that come about with wear and tear arthritis. If you don't get that swelling and that inflammation, that pain, a lot of times you don't feel a lot of that pain and you don't end up at the doctor. I've actually got osteoarthritis on my x-rays. I don't feel it. I can have somebody come into my office and I do a knee film on them. They have no cartilage left. Doctor, I'm fine. I don't need anything today. I can have somebody come to my office, their knees look perfect on an x-ray. My knee is killing me, and they have osteoarthritis underlying it. And that has to do with the inflammation more than with the actual damage of the joint itself. The synovial fluid within the joint, that's the fluid in the joint that helps lubricate the joint, helps keep it together, actually becomes less effective as well within osteoarthritis because of the inflammation and because of the extra fluid that's being inserted in it. It actually loses its ability to hold the joint together and lubricate the joint, and that causes progression as well. So here I've got an example of osteoarthritis. This is a very common place for osteoarthritis to affect people in the distal joints of the fingers. So the joints all the way out here and the middle joints of the fingers. Notice that the knuckles aren't affected here. Osteoarthritis typically doesn't affect the knuckles. It typically likes to affect the middle joint and the farther joint here. This is bony enlargement. If I press on this, it's bone. It's not soft tissue. And so the joints have actually grown extra bone to try and make up for that laxity that comes about from loss of the cartilage. Here, this is actually a surgical specimen of a knee. In this patient, here's the kneecap. It's flipped down over. Here's part of the end of the bone. All of this white is cartilage. Right here, there's no cartilage. It's denuded away. It's eroded. And that's what happens in osteoarthritis, is that cartilage just wears away, and underneath you irritate that bone and it starts to get extra growth. This one, of course, this was my favorite dish. This extra calcium growth along the ligament in front of the spine. So this spine actually grew extra calcium. These are spinal bones here, vertebrae, each one here. Grew extra calcium along this, fused that spine to where the person could no longer move their back. And that happens. It's actually a rare disorder, but it's one of our degenerative disorders that occurs. Here's an x-ray that demonstrates some wear and tear arthritis. If you look at these joints here, we've got a little space in between the bones here. That's where the cartilage sits. Up here, there's no space anymore. That's osteoarthritis. That's the damage. That's what we're looking for in x-rays. There's no more space in these joints because there's no more cartilage. And those bones have actually fused together. And if you notice, there's these nice smooth corners and edges here on these bones. You don't have that here. You have these rugged areas on the bones. That's the extra bone growth that the joints are doing to try and make up for the loss of tissue. Similar, here's just an increased picture of the beginning of some of the osteophytes, so the extra growth of bone that actually gets larger as it goes here. And that forms the nodules that you can feel on the outside. Now here's examples in the knee. Here, this is a normal amount of cartilage between the bones. We don't actually see the cartilage. We're looking at shadows of 3D structures here. But there's cartilage in between the bone. That's what causes this space. Here, no more cartilage. That's what happens in osteoarthritis. This is what we're looking for in the knee when we're looking at people who have osteoarthritis. There are 3 compartments in the knee. One of them can have the arthritis, or all of them can have the arthritis. It just depends on how bad or extensive it is. Now, osteoarthritis typically, like I said, causes joint pain. The morning stiffness that comes with it is usually about 30 minutes, 40 minutes. As you move, it gets better. And that's the stiffness itself. I didn't say the pain. The stiffness gets a little better. Keep that in mind when we get to rheumatoid. Gelling phenomenon occurs in this as well. You sit down for a few minutes, and then you try and get up, and the joints don't want to move, and it takes a few minutes to get them moving. That's what we call stiffness after some inactivity. This usually lasts a few minutes to a few seconds, depending on how bad the swelling is or inflammation is. Most people who have osteoarthritis, their pain is worse in the evening. When I've been working all day, I hurt more later than at night. I can't sleep. That bed's not comfortable. The pain worsens with activity, which is different from all the other forms of arthritis I'm going to talk about today. And then you can get weakness. Now, a lot of times when you have osteoarthritis and you have some mild pain in the joint, especially in a knee, you might favor the other knee, put more pressure on the other knee. Well, your muscles on the other side will get a little weak. As they weaken, the joint gets more lax. As the joint gets more lax, guess what? The knee gets worse. The osteoarthritis gets worse over time. So weakness of the muscles can occur around the joints. You get swelling in the joint, bony enlargement like I've shown on the x-rays, and decreased range of motion. Why does it happen? We don't know. We don't completely understand the process. All of the things that I've discussed with you, we know there's some underlying genetic cause in many people who have osteoarthritis where the cartilage itself becomes very stiff and rigid and doesn't get repaired well. But that's not the whole story, and we know that's not the whole story. There are a lot of people who are saying that we also get an imbalance in the proteins in the fluid that help us build up and break down that cartilage. And that imbalance causes a greater breakdown. And so there are people who are looking at trying to treat that. But this is a hard thing. There's no one cause that we can pinpoint on every single person and say, this is why you got it, let's stop it by doing this. We just don't have that yet. It's a very difficult disease to understand. A lot of people do have a genetic predisposition to it, which means they inherit it in their family. Usually I like to tell people, this is usually inherited more down the mother's line. Thanks, Mom. So, it's one thing you can blame your mother for. Like I said, the genes typically that we know of code for an abnormal cartilage repair. But you can have an abnormal shape to the joint, abnormal stability, or just be born with joints that don't fit correctly, and these people are actually at increased risk of getting osteoarthritis. There is some people who actually have an increased laxity in their tendons. Their tendons are really loose, and they can put their joints through more of a range of motion than other people. We call this benign joint hypermobility syndrome. Well, they're at more risk for getting osteoarthritis as well. What are other risk factors? Well, a lot of things you're going to hear commonly, probably among all of the diseases that you've heard about today. Obesity, obesity, obesity. If you got to put more weight on that knee, guess what? That knee is going to progress faster. You're at increased risk when you have an increased weight for developing osteoarthritis. So there are some people out there who feel if we prevent that weight gain or we lose that weight, we can prevent progression of the damage in the joints, especially the knee, especially the ankle, especially that first toe. In the knee, you feel a lot of pressure, probably 2 times your upper body weight. The ankle can feel up to 10 times, 5 to 10 times, or actually I take that back, it's about 8 times your body weight. That first toe, when you step off of it, can feel a lot more than that. And so all of those can get damaged very easily just because of the weight that is on them. Muscle weakness. So if you've been inactive for a period of time and your muscles are actually more lax, like I said, you can damage that joint much more easily and damage the cartilage much more easily. And so anybody who's got a lot of muscle weakness has an increased risk of developing wear and tear arthritis. Injury or overuse. This is the people, oh, I played football in high school and I got that tendon tear. You injure that joint significantly, you are more risk getting osteoarthritis in that joint than the other joint. So football injuries can cause this. Certain jobs, they say, are at increased risk of progression. Now, when I say progression, I say that's different than actual getting the disease or having the disease. Progression means that the disease gets worse over time. So you have an increased risk of progressing or getting worse over time with jobs like being a miner, shipyard workers, dock workers, those types of things where you're lifting heavy things. You want to be able to modify lifting and those things to try and avoid worsening of osteoarthritis, but still, that's the progression. That's not getting the disease. We have other studies that show us that somebody who's sitting at a computer all day long and typing versus someone who's working in a shipyard can get the disease at the same rate. It's just the person in the shipyard gets it worse faster. Aging, of course, as we age and this process continues, the cartilage actually worsens over time, and so more people present over age 65 with complaints than people who are younger than 65 just because of the nature of the disease, not necessarily because there's more people who have it later on in life. Can it be prevented? Well, if you have a genetic predisposition, there are some people who think we can prevent it by ensuring that you don't gain too much weight, by staying active with low-impact exercise, avoiding significant injury to the joints. And there was some time when we thought some of our treatments might actually prevent progression, especially the injectable joint fluid replacements. But it looks like those may or may not do it. We're not completely sure because the studies weren't that great on it. So we're still trying to look into things that prevent the progression by medicine. But most of what I've talked about, what are they? Lifestyle changes, not medicines. Osteoarthritis is more modifiable by the things that you do in your daily life than by me giving you a medicine. So, how do we diagnose it? Well, typically for most people, when you come in to see a physician, we sit down and we talk with you first. By the time we're done talking with you, we know with a 90% to 98% certainty what's going on. We already have either what's going on or we got a short list. Then after that, we take a look at you. We do the exam. Typically by then, we're either whittled that list or confirmed what we thought. And then we're using the x-rays to see how bad is it and using the labs to make sure I don't hurt you with something I'm going to do. And that's basically where we would go with osteoarthritis. Rarely, we do aspirate the joints, so we take fluid out of the joint, mostly when the joint is painful and there's a lot of swelling, because if you take the fluid out, sometimes that pain gets better just by taking the fluid out. And sometimes we do, like I said, blood tests, mostly to ensure that there's nothing else going on and that I'm not going to hurt you with anything I'm going to give you. So how can it be managed or treated? Notice, I don't have anything up here that says, well, this is how we cure it. There's very few things these days in modern medicine that we actually cure. Most of the time we manage these diseases. So what we try to do when we get someone who's got osteoarthritis is to decrease the pain, decrease the stiffness, improve joint mobility, and try to get people to be able to do their daily duties. Go to work, go home, enjoy their life. And that's what we're trying to do with most of the things that we plan to do. Treatment can include joint surgery, usually if necessary, but when you come to see a rheumatologist, we're trying to stave that off as long as possible. We usually use medical management and exercise and different things to push that away as much as possible, because you can only get so many joint replacements in one joint in your life. So what we usually start out with is different types of exercise. Physical therapy and occupational therapy can teach you very good ways to stretch and do those exercises. That way you can form a plan and do them on your own at home. Once you have osteoarthritis, you have it. It's there the rest of your life. If you want to continue to improve and make sure that your joints do well, your muscles are strong, you have to continue the exercise the rest of your life. Otherwise, things are going to worsen, get worse over time. Physical therapy and occupational therapy improve your range of motion, and they can actually help you get assistive devices, canes, walkers, things like that. Canes themselves actually decrease pain by offloading pressure on an abnormal joint. A lot of people don't want to be seen with a cane, but they actually do work and prevent people from getting joint surgery over time. Depending on whether you have acute inflammation or chronic pain, heat or cold therapy can help. Stretching helps prevent joint stiffness and increases flexibility and improves overall well-being as well. And so there's a lot of things here. Notice what's first. I didn't say, let's go out to the store and get some medicine. Let me give you this prescription. All of this is lifestyle changes. And you're going to see this across the board in a lot of diseases that we treat. Diabetes, hypertension, high cholesterol. If we do these lifestyle changes, a lot of times we can modify all these things as we go forward. Aerobic exercise in itself reduces pain. Typically swimming, biking, ellipticals are very good for the joints. They improve the muscles around the joint, strengthen those muscles so that the joint remains within its normal position and doesn't cause any worsening of the disease. And then on top of all that, weight control. Controlling your weight is a very important part of treating osteoarthritis. A lot of physicians don't like to sit down and tell you you got to lose weight. It feels so uncomfortable sometimes in the room, but it's something you have to think of, whether your physician says it or not. Losing weight can affect a lot of other things if you have too many pounds on. So keep that in mind. Notice I went through all of those things, are all things lifestyle management, and now I'm talking about medicines. Why is that? Because those things may prevent the progression. These medicines don't. All they do is help treat your symptoms. Okay? Nutritional supplements. So there are a couple of supplements that have been studied out there. The most famous one is usually glucosamine. And when you look at the studies and look at the recommendations, most people would tell you, glucosamine doesn't work in the studies. When you look really close at those studies, there are two forms of glucosamine, and unfortunately all those studies got lumped together. But it looks like glucosamine sulfate actually helped a bit. Whereas glucosamine hydrochloride, which is HCl, you can look at the back of the bottle and tell which one's on there because it's not going to tell you on the front. You look on the back. Didn't seem to work. And so when they lumped the studies together, it all looked like it washed out. Remember, when we do these studies, we give people sugar pills and then we give them glucosamine. 40% of people feel better with that sugar pill. So to tell a response, we got to get a little above that. And so the glucosamine hydrochloride didn't do better than that. But the sulfate did by 60%, which isn't much. It's almost like tossing a coin. So what I usually tell people is, if you're going to try this, you try it for 6 weeks. If it's not working, toss it. You're wasting your money. Because for some people it works, some people it doesn't. Fish oil has actually been studied as a good anti-inflammatory. It was studied in rheumatoid arthritis. Unfortunately, rheumatoid arthritis, as we're going to talk about, is mostly inflammation. It's way too much inflammation for that. But I find in osteoarthritis, it's just enough in some cases. So some people do well with fish oil. We also have analgesics, Tylenol, Tramadol. These medicines help reduce the pain that are associated with it. Typically don't help the stiffness. Non-steroidal, so these are medicines, Advil, ibuprofen, BC, Goody, Stand-Back, these medicines over the counter, and the prescription strength ones are anti-inflammatories. They reduce that inflammation we were talking about earlier. That inflammation that causes the pain, the stiffness, the swelling. And so these are usually the mainstay of therapy when you see a physician, unless you have some reason not to be on these medicines. We also have a lot of topical medicines that do some of these things. We have the anti-inflammatory medicines, and we even have some that are like the Voltaren, the prescription strength anti-inflammatories. And then we have capsaicin, which if you've ever used capsaicin, you put it on that joint, on the skin, and it burns. Well, it causes all that burning, and then the nerves around that joint send so many pain signals, it cuts it off, it can't send any more. So you don't feel the joint pain anymore. And what it does, it just tricks the body into saying, well, there's pain now, and now I can't put any more pain in there. And so that's how it works. It's pretty interesting. Injectable glucocorticoids, so steroid injections we use to reduce the inflammation, often help decrease pain and stiffness. We can only do so many of these, but they work pretty good for some people. Some people they last 2 weeks, some people last 6 months. It just varies from person to person, and we don't know until we do it. Underneath here, the joint fluid replacement, hyaluronic acid. Joint fluid replacement, when we give you that, that's also an injection in the joint. Now, most people think I'm replacing that fluid in the joint, and so that's why it's helping. That's actually not it. It's actually anti-inflammatory, so it decreases inflammation again. We know this because this stuff is no longer in your joint 2 weeks after I give it to you, but it lasts up to 6 months. We stop that inflammation for a short time before it comes back. And these medicines often keep people from going to a joint surgery. And so we can use these oftentimes to prevent surgery for 6 months, a year or so in somebody who's got very severe osteoarthritis. Acupuncture. I've actually had a couple of questions about this morning. Acupuncture, there were scientific studies on acupuncture, and it did reduce joint pain in the knee, patients who had osteoarthritis. It improved mobility and flexibility. Now keep in mind when we do these studies, we look at different arms. So what we do is we put somebody, we didn't touch you, we did acupuncture on you, and then this last one, we got somebody who knew nothing about acupuncture to stick needles in you. Now, not exactly a study I would have liked to have volunteered for, but what we showed was the acupuncture reduced pain, reduced stiffness, and improved mobility, but so did the person who didn't know what they were doing when they put needles in. Well, it's almost like the capsaicin, where you induce enough pain, you stop the ability to bring those pain signals up. But still, what I usually recommend is that if you're going to get acupuncture, please see a professional. Don't do it with somebody who doesn't know what they're doing. Okay? If somebody wants to do it and comes to my office, I usually tell them, yeah, go ahead and try it and see if it works for you. It's not covered by insurance, so it's usually an out-of-pocket expense, so just keep that in mind. And then after all these modalities and medications, If we still can't improve the symptoms, we tell people to go to surgery. And there are a lot of different types of surgery. There's the type of surgery where they put a small little scope inside and they scrape the cartilage and try and make it look a little smoother. That's called arthroscopy. We have one where they actually punch holes in the cartilage and try and get the cartilage to heal over itself, osteotomy. We also have surgery where we actually take a piece of cartilage from the back of the knee and try to put it on the front. It's a cartilage transplant or graft. And we also have, if all of that fails, joint replacement, which for the knee, a lot of people end up going to joint replacement, which has a good response, but unfortunately, you've got to exercise that joint after the joint replacement or you won't ever get that full mobility back. And so there is still exercise involved once you get a joint replaced. You don't just fix the whole problem, especially if the muscles have gotten weak over time because of the arthritis you've had. There have been a few experimental treatments out there, people trying to find things that stop that progression of the arthritis. And so there's a lot of studies on things, these injectable medicines that actually stop some of the breakdown. The studies haven't looked too great yet, and so we're still trying to find something that works well for osteoarthritis. All right, so I want to give everybody a small break right here. Stand up, kind of stretch, and if you've got a question, I'll actually answer any questions right now. And then we're going to get into rheumatoid arthritis and gout, and we'll try and get through those. So go ahead and we'll take a couple minutes here on arthritis. First off, I want to talk a little bit about rheumatoid arthritis, and then I'm going to get to something that affects men a little bit more commonly as well, is gout. So starting off, we're going to talk a little bit about this one. Now, some of the reasons I chose these three types of arthritis is because they actually are three different forms that represent three completely distinct classes of arthritis. Osteoarthritis was our wear and tear. Rheumatoid arthritis is our autoimmune, so the body's own immune system attacking your joints and the rest of the body. Gout is a metabolic, and we'll talk about that when we get to it. So rheumatoid arthritis is a form of an inflammatory arthritis, and like I said, it causes inflammation in the lining of the joints because the body's own immune system is attacking the lining of your joints. It causes warmth, swelling, and tenderness within the joint to a much greater degree oftentimes than osteoarthritis does. It causes pain and decreased range of motion as well, just like osteoarthritis does. It can persist for many years, and rarely it does go away, but most of the time it continues on throughout the patient's life once they've got it. It affects many joints at one time. That's actually one of the hallmarks. And it does damage the cartilage, the tendons, the ligaments, and the bones all together. And I'm going to show you some very drastic pictures of what happens when you don't treat. About 0.5 to 1% of the United States population has rheumatoid arthritis. And by estimation, that's about 2.1 million people. So this is what rheumatologists see a lot, is rheumatoid arthritis. It's kind of where some of the name is derived. Most commonly, though, it begins usually in the 30s and 40s, age-wise. And women are affected much more commonly, 3 to 1, but it still affects men. And oftentimes goes more unrecognized in men just because it happens less frequently, and men tend to push a lot past their pain and not want to focus on it. They want to get back to work. They want to do their job. And with this arthritis, when you're moving and you're active, it feels better, as opposed to wear and tear arthritis, which feels worse. It occurs in all ethnic groups. In China and Japan, though, there's a decreased frequency of 0.2 to 0.3%. In Native Americans, though, there's 5% of Native Americans actually have rheumatoid arthritis. So it does vary a little bit. So what causes it? Well, we know that the immune system attacks the joints. That's what we talked about. The immune system is actually the body's defense mechanism. This is actually the mechanism that helps prevent bacteria, viruses, fungi from actually catching hold and causing us to get sick. Unfortunately, that same system can look at parts of the body and say, oh no, that's a bacteria, and start to attack something that's actually normal in your body. Inside the joint, when you start to get this inflammation, fluid starts to build up, and these cells that create that inflammation build up, and the joint itself, the tissue lining the joint, actually grows bigger, invades the bone, and erodes the bone. And that's a very, very large hallmark of what happens within rheumatoid arthritis. Rheumatoid arthritis is inherited in many cases. It does pass down the family. Now, when I say that, there are families out there where the mom's got rheumatoid arthritis, one of the kids have rheumatoid arthritis, one of their kids has rheumatoid arthritis. And then there are families that just are prone to getting autoimmune disease. Aunt's got lupus, brother's got rheumatoid arthritis, sister's got ankylosing spondylitis. I mean, all around. So there are some people in the families where they have very different diseases, but it still runs in the family. And so there is a genetic predisposition within people who have rheumatoid arthritis in most cases. Now, the gene for rheumatoid arthritis is a lot more common than the actual number of people out there who have rheumatoid arthritis. Well, why is that? Well, it takes two things. It takes the ability to get rheumatoid arthritis, and then it takes something to trigger the immune system to turn around and attack your joints. Now, what is that? Well, there are too many triggers out there for individual people for us to know what all of those triggers are. It could be a viral infection, and there are hundreds of viruses, thousands of viruses out there. It could have been a bacterial infection. The one thing we know that predisposes many people to rheumatoid arthritis 10 times more than the average population is smoking. Now, people who smoke are 10 times more likely to get rheumatoid arthritis than people who don't smoke. And I oftentimes have to sit down and have a conversation about smoking with people who have RA, just because even though now you have it, the smoking triggers flares of the rheumatoid arthritis. The smoking inactivates the medicines I'm going to use for your rheumatoid arthritis. The smoking prevents you from healing the tissue that's damaged. The smoking prevents you from actually growing new blood vessels into those tissues that are damaged. And the smoking can actually prevent the blood flow to where I need to get that medicine that it doesn't inactivate. And so smoking overall actually inhibits our ability to treat rheumatoid arthritis. And so I often have to end up having that conversation. Some people actually get their first bout of rheumatoid arthritis and begin the disease after injuring a joint severely. Let's see. Sorry, I think this went back. Okay. What are the symptoms? Well, the symptoms of rheumatoid arthritis actually vary from person to person, and it depends on how it starts, really. There are some people who get rheumatoid arthritis and they start to get a joint that's swollen and painful, and then they get another one, and over this long period of time they end up adding up to a bunch of joints that get swollen. Over that period of time, they've had time to adjust and get used to it. And so they don't really come to me when they hurt. They come to me more, well, I got all this swelling in my joints. What is this? And then there are people who get all the joints swollen at once, and they hurt because it happens so rapidly. There's pain, there's swelling, there's redness, there's stiffness associated with it, and they come in when it happens right away. And so the symptoms can vary in anywhere on a spectrum within that. These people usually prefer to remain active because the inflammation improves slightly as you move. The pain, the swelling, the stiffness actually improves as you're moving. The inflamed joints actually appear swollen, red, tender, painful, like I talked about. You can actually develop morning stiffness with this just like osteoarthritis, but this morning stiffness, when you get up and start moving, it takes hours for it to get better instead of a few minutes to an hour. You can damage the cartilage, the bone, the tendons. Now, this isn't just a disease about the joints, though. And we're focusing on the joints because that's one of the easiest manifestations to see. But this is a systemic inflammatory disease. The whole body can be affected. And so this can cause overall feeling of just sickness. And that's what doctors call malaise. Again, you know, we're talking about the wording, how doctors use different words. Weight loss. So your body can't keep up with the metabolism because your immune system is so active. Decreased appetite. Tiredness. So just chronic fatigue. Low blood counts can occur because of the chronic inflammation. And then you can start to develop other systemic signs. Nodules along the edges of the bone. And these occur usually on the extensor surfaces, on the elbow, in a couple of other joints as well. You can get inflammation that lines the heart and the lungs, nodules in the lungs. You can get inflammation within the eye, dryness in the eyes and the mouth that is chronic, vasculitis, which is an inflammation within the blood vessels that can cause breakdown and ulceration of the skin. All of these things. Now, many of these occur in people who have long-standing disease. These days, we have ways to recognize and treat it earlier, and if we can do that, we can prevent a lot of these other symptoms systemically that I'm talking about. But if we don't, these things can progress on and occur. So here, this is a little bit of a more subtle picture, but this patient actually has swelling in the middle joint here, and has a little bit here on this joint here. Now notice, osteoarthritis hit these joints and the middle joints here. Rheumatoid prefers the middle joints and these joints here. So there are ways we can look at you and help to figure out which type of arthritis you actually have, just by what the pattern is. And so that actually helps us out a lot when we do exams. This is an advanced case of rheumatoid arthritis. This patient actually had significant damage within the joints. She cannot actually extend these fingers. They're stuck this way because the joints have actually fused like this. And she can no longer use these hands except to squeeze and pinch. And so that's what happens with patients who don't get treated. Swan neck deformity, same thing. These joints can't move. They're stuck this way. Now, I can't extend those out or straighten them. Here, a very advanced case called arthritis mutilans. Occurs more commonly in psoriatic arthritis, but can occur in rheumatoid arthritis as well. Down here on the elbow is a nodule from the inflammation in cells that build up on the edge of the bone. You can get those in the lung as well. And here we can see a little bit of a progression over time. This is the same joint over time. Normal line, there's cartilage in here because you see that space. The edges are pretty smooth. Then slowly we begin to see there's something going on right here. And then an erosion over time. And that's how it starts. That's the beginning. That's one single erosion within that joint. And then over time they collect and then you end up with the joints the way they look on those other x-rays. So here this patient actually had loss of the cartilage, fusion of these bones in that position, and she can no longer extend them out. Here are some lung nodules. And oftentimes people get sent to get biopsies of these because they're worried these are cancer. And they come back with just inflammatory cells, and sometimes those are lung nodules from arthritis. So how's it diagnosed? Again, through history, examination. We have some blood tests. But keeping in mind, these blood tests, the rheumatoid factor and the CCP are the ones that are most commonly ordered. They can be negative, both of them, and you can still have rheumatoid arthritis. So now you're going to look at me and say, Doc, what good are these expensive tests for? Well, these tests, if they're both positive, tell me that you're going to erode and damage your joint over time. If they're both negative, it tells me you're less likely to get that kind of damage. It's mostly going to be swelling and joint pain over time. And so they do help me decide where do we go with treatment, where do we start with treatment. X-rays can tell me how bad they are. Ultrasound can actually detect the swelling and inflammation before I can feel it on exam. And so we have some ways to detect all of this before you have enough symptoms to actually make it very, very easy to detect on exam. Nuclear scans and MRI can do the same thing as well. Early treatment's essential. What I usually tell people when they come to see me for rheumatoid, I got two goals, and they don't necessarily go together. The first goal is to get you feeling better. Less pain, less stiffness, good mobility. The second goal is to prevent the damage that can occur over the next 5 and 10 years. And so you may see me in an office sitting down and talking to you and telling you, I need to go up on your medicine. And you're looking at me and saying, Doc, but I feel fine. Well, that's because I'm trying to prevent damage. I see something that tells me the disease is still active even though you feel good. They don't always go together. There are two big groups of medicines that we actually use to treat arthritis. The first group is just to help with the symptoms. The second group is to stop the arthritis in its tracks and try to prevent that damage. The symptomatic treatment medicines include Advil, Aleve, ibuprofen, BC, Goody, Stanback, and all of the prescription strength anti-inflammatories. We often use them for pain relief and reduction of stiffness. Same thing, analgesics, Tylenol, Tramadol, narcotics actually help reduce the pain. Don't stop the disease. Steroids, we actually use them to reduce that inflammation dramatically and often use that first while we put you on another medicine and wait for the other medicine to start. But they don't suddenly stop the disease. They just help reduce the inflammation. These are medicines we use to stop the disease. Methotrexate is the most common medicine we use to treat rheumatoid arthritis, and it reduces inflammation and stops progression and erosion. Many of these other medicines decrease the disease but don't stop the erosions as much, such as Plaquenil and sulfasalazine, leflunomide, may do it. We don't have enough studies on it. Azathioprine and cyclosporin. All of these medicines work by reducing your body's immune system's attack on the joint. So it reduces your immune system activity. Just enough to stop the attack, the abnormal attack, but to continue to maintain your ability to fight infection in most cases. These medicines are either injections or infusions that we use to stop rheumatoid arthritis, and most often we use them with the methotrexate. So if I know that you're going to be one of these people who are going to do damage to your joints or erode, or have already done so, I'm going to try to get you on one of these medicines and make sure we get you on something that's going to work well. These stop the disease in its tracks. So that was rheumatoid arthritis. I'm going to talk quickly about gout as well, since this is one that actually affects men, and this is a whole nother type of disease. This is metabolic arthritis. So gout is an inflammatory arthritis. It's just caused by there's a different cause for it. It's not the body's immune system attacking the joint. It's actually waste product building up in the joint, and when it's released, the immune system thinks you're under attack. You have an infection or a virus. And so uric acid is actually a waste product of our metabolism. That uric acid builds up in our body. And when it builds up in the bloodstream, we don't have anywhere to put it. And so we start to put it into the tissues. We put it in the cartilage. We put it in the tendon. We put it in the muscle. We put it in the bone. While it's being put in there, it forms little crystals. And if we do something that damages the cartilage, damages the joint, or causes a change in the level in our bloodstream of that uric acid, crystals form inside the joint or get released into the joint. And then your immune system sees those crystals and says, oh my God, that's an infection, and attacks it real suddenly. When that happens, you get this big, red, swollen, painful joint. You wake up with it most often. It usually happens overnight. You wake up with this huge swollen joint that you can't even lay a sheet on because it's so tender. The pain is so intense. They say it's the closest thing a man can experience to childbirth. So ladies, if your man's ever had gout, he feels your pain. Okay? It can be acute, which is what I've just described, which means it happens suddenly, lasts for 7 to 14 days, and goes away on its own without treatment. Or it can be chronic, where you've had so many attacks that they start to fuse into each other and you just have joints that remain chronically swollen. Almost looks like rheumatoid arthritis and can be easily misdiagnosed. It damages the joints, the soft tissues, the bone. It can even cause kidney stones. How common is it? Now remember, I said rheumatoid arthritis is 0.5 to 1% of the population. Gout's almost 3 times that. I see more rheumatoid arthritis in my practice than I see gout. Why is that? Unrecognized, and primary care doctors like to treat gout. And many of them do a very good job at it. When they have trouble, they'll send them to me, and then I go further. So there are a lot of different people out there who need more treatment than what they get from their primary care, and sometimes they come to us for that. Sometimes that includes infusional medicines. So who gets gout? More commonly men than women, but women can get it very commonly after menopause as well. What causes it? Like I said, that retention of uric acid that gets deposited in the joints. But a sudden change in that uric acid level in your bloodstream can either push too much into the joint or pull some out of the joint and cause crystals to form in that joint. When that happens, you get an attack. So we were talking earlier about what are some of the foods that can cause it. Well, there are some foods that act like our medicines. Cherry juice makes you reduce your uric acid level. Unfortunately, you can't control the level or amount of cherry juice, the chemical inside the cherry juice that does that. And so some people who have gout and they go to take cherry juice actually cause their uric acid levels to bounce up and down. And they end up getting more attacks than less attacks, even though we know it's actually a medicine that would treat it. It's just because you can't control the concentration of that cherry juice in there. Here's what it looks like. So this one's in a finger. Huge, red, swollen, painful joint. Looks terrible. When we take fluid out of that joint, what do we see? These little shards of glass. These are crystals. Now, they look terrible. They look sharp. You can imagine how they might cause pain. It's not actually the sharpness that causes the pain. It's actually the inflammatory response to those crystals, the swelling that causes the pain. But that's what we see when we take it out of a joint. Up close, this is what they look like, little needles. When I put this under a microscope, I can change the angle of light going through it. They change colors. That's how we can recognize gout. The only way to 100% diagnose gout is to pull fluid out of a joint that you think is affected and see these crystals. It's the only way to 100% prove it. You can have a high uric acid and not have gout at all. You can have a normal uric acid and have gout. Most of the time that happens when you're having an attack because your uric acid levels actually drop when you have an attack. And so many doctors, they'll see you, oh, you got an attack, let me check your uric acid. Oh, it's normal. What's going on? Well, a lot of times that's because the uric acid level drops when you have that attack. You got to take it between attacks to diagnose, to help diagnose. So we talked about acute gout, which occurs intermittently, one joint usually, lasts 7 to 10 days, usually without treatment, will go away. So I don't even touch it. It'll go away. But guess what? You suffer for 7 to 14 days. So what happens? Well, this is actually one of my favorite pictures depicting, this is the artist's rendering of the pain from gout. If you ever had it, you can feel what this is trying to represent. So you understand this picture. Then we also have advanced gout, which is chronic gout, where it starts to just become all the joints stay swollen, stay inflamed, stay painful. Here are some pictures again. More joints affected by gout, you can see. These are nodules called tophi that form. All of that's full of crystals. All those knots are full of crystals. Those crystals and those nodules actually damage and erode the bone as they form. Risk factors. Well, just being a man puts you at risk. We have a higher uric acid level on average than most women, so that puts us at risk. Women, once you go into menopause, your uric acid level raises, you're at risk. Obesity raises our uric acid levels. Hypertension, higher purine diet, which means more red meats, more organ meats, liver, gizzard, sweetbreads, all of that increases your uric acid levels. Alcohol can precipitate an attack. More commonly, beer, because of everything else that's in beer, has more purine, can create and cause more uric acid to build up in your body. So how do we treat it? Well, if you've got an acute attack, we try and reduce that 14 days to 1 or 2 days by giving you something to reduce the inflammation. Most often, that's an anti-inflammatory, like a medicine like Advil, Aleve, ibuprofen, but prescription strength. We can also use colchicine, which reduces inflammation, or we can use steroids. These are the 3 things we have that can reduce that 14 days to 1 or 2 days. Once you've got that treatment done, we want to try and prevent the next attacks. The way we do that is by reducing that uric acid to a stable level over a long period of time so that your body has a chance to seep all of that uric acid out of the tendons, out of the bone, out of the cartilage. And guess where it goes? You urinate it out. It goes out through your urine. So we've got medicines, one, that helps you urinate it out. Probenecid makes you urinate more of it. Allopurinol and febuxostat actually help you stop making more of it. Uricase, which is an infusion that people get twice a week when they have very severe, uncontrollable gout, actually converts the uric acid into something that goes out of your body easily and doesn't collect. And so that we reduce the levels of gout. These are chronic long-term medicines to prevent gout. And trust me, you do want to prevent it because even if you can control the attacks, if you get enough attacks, you actually damage the joints and can get some problems just like rheumatoid arthritis patients with fusion and damage and disability. So those are the things I wanted to talk about with y'all. Anybody have any questions? It's right here. Typically, it's very hard to detect if it's in the hip joint. If you get it in the hip joint, that's where you're going to feel it in the groin. So most hip pain, real hip joint pain, is in the groin. Most people come to me and say, my pain is out here on my hips. This is actually mostly tendons. Right in the center in the groin is usually the actual joint. It's actually not an easy spot to detect if you've got it, but it's not impossible. You can get it there. We've actually had some case reports, it's very rare, to get it in the spine. So that's extreme cases of gout. Over here.
On giving arthritis medicine,
Mm-hmm.
I found, and I had experience with it, where it caused bleeding of my colon.
Right. The anti-inflammatories, like Advil, Aleve, ibuprofen, but also the stronger ones that we use, can all cause stomach ulcers and colon bleeding. And that's one of the more severe side effects we actually want to watch for. So when I start somebody on these medicines, I'm watching blood counts over time in many cases. It's one of those things we have to be careful with, and that's why we tell people, if you've got to take these medicines for any long period of time, don't just use the over-the-counter, go see your doctor. That's why they have all these warnings, don't use it. If you've got to use it for more than this many days, please consult your doctor. It's because there are some risks with these medicines. Any other questions? All right, well, thank everybody for coming. I hope you enjoyed and learned something.